Hi guys, I'm Shivani Trehan and welcome to my channel Social Cravings. In today's video, I am going to make you meet Dr. Abhishek Mangeshikar, who runs the Indian Center for Endometriosis, the ICE, where he has actively taken up the cause of spreading awareness about endometriosis. Now, many of you would not have heard about this condition, and therefore endometriosis has not gotten the attention that it deserves. But first, I'm going to talk about some staggering figures about endometriosis which shouldn't be ignored. As per the Endometriosis Society of India, about 25 million of women in this country suffer from endometriosis, and this number is increasing every year. And according to the Endometriosis Foundation of America, approximately 176 million of women suffer from endometriosis worldwide. With 1 in every 10 women suffering from endometriosis, chances are that you would most likely know a woman who has endometriosis. Given that it takes an average to about 7 to 10 years to detect and diagnose endometriosis, experts call this a silent epidemic. The woman may not even know that she has this condition. A key reason why women should be aware of this disease, endometriosis, is because it's quite common and it's not rare at all. In fact, as common as asthma or diabetes. In fact, more women suffer from endometriosis than even breast cancer. However, despite all this, endometriosis receives only a fraction of the millions of dollars which is spent on other diseases in terms of research funding. Now, just before we go and meet Dr. Abhishek, who is doing some incredible work for women with endometriosis, just a little brief about his medical background. Now, Dr. Abhishek is an endometriosis excisional specialist who comes from a family of gynecologists. He has trained extensively in laparoscopy from one of the most advanced centers in gynecologic endoscopy. He also underwent a 2-year fellowship in minimally invasive gynecology from Shangang Memorial Hospital in Taiwan. I'm trying my level best to pronounce everything correctly, but please spare me if I'm not. He is performing more than 250 surgeries for advanced endometriosis every year and is also teaching the same. I will put more of his details in the description box below for you to have a read.
So, hi, doctor. I hope you're doing well.
Hi, Shivani. Thank you for having me and thank you for doing this. And I'm happy to be here and give time to the cause that we both support is endometriosis awareness and education.
Great. So, doctor, that's a lot of surgeries that you do and a lot of specialized surgeries in the field of endometriosis. And it's not every day that we come across someone, who specializes in this field. So my first question to you would be, considering I recommend natural therapies and natural remedies myself, and even for my personal journey, I have done natural remedies and I have been able to reduce my cyst size. Now, why is it that when we go to any doctor or any gynecologist, that they don't recommend the natural way, in place of hormonal treatments, in place of medications, or in place of surgeries?
Right. So that's a good question. So I believe the approach to endometriosis care should be holistic and integrated rather than, everybody should be in their own camps recommending one form of treatment over the other. It's more importantly, what we need to understand is when a scientific process is looked at, that scientific process is peer-reviewed and should be reproducible with measurable results. So that's how a peer review process works. So out of what the current treatments for endometriosis are, as a doctor, we use what we know. So we have surgical treatments which show vast improvements in pain scores for long-term, and excision, what we do by removing the disease, shows the lowest rates of recurrence and the longest time of disease-free periods versus hormonal therapies, for example, which are used for symptomatic control of the disease. They are not used as treatments. They are used to control symptoms. Moreover, what you said from your personal experience, usually a lot of patients have come and, we said, they will say, okay, my cyst size is reduced. But the volume of a cyst or the size or the diameter is not really indicative of progression or regression of the disease, because it's not
Okay.
like the fluid within a cyst will vaporize or something. If it's reducing in size, that usually means it's leaking out into the pelvis and creating a lot more adhesions and disease outside the ovary. Unfortunately, that is not measurable, but you can look at the fibrosis that it's causing over time. So a nodule to where the ovary will be adherent to will increase in size, even though the ovarian size may be decreasing. So that may lead to a false sense of that. But again, natural, so holistic therapies like nutrition, anything to reduce inflammation, or even exercise to improve circulation in the area will cause a reduction in symptoms. But the overall quantum or spectrum of disease will either stay the same or progress in that case. But the symptoms may become reduced.
So aren't the symptoms a reflection of how you're progressing with your treatment?
No, that's a good point you've touched upon. So, arbitrarily, according to the American Society of Reproductive Medicine, what described it as stage 1, 2, 3, 4. It's actually quite a useless staging system because it has no bearing on symptoms. So stage 1 patients which have superficial peritoneal disease may have 10 times worse symptoms than someone with a fully frozen pelvis, bilateral cysts, a nodule in the rectum, etc. Their symptoms, they may even be asymptomatic at that stage. So the severity of disease has no reflection uh, on the severity of symptoms. So they're not proportional to each other. And I think that is something very important to understand. There are newer staging systems coming out, more to deal with complexity of surgery and the extent of the disease that has occurred, rather than, there is an index to measure fertility outcomes for patients who do have that desire and goal in mind. But regarding pain scores, that is a very difficult thing to measure. It's a subjective measurement. And also, the extent of the lesions may not necessarily be as reflective as the actual pain that the patient may be experiencing.
Yeah, because I guess this is a sort of a disease where it's different for all women. Women who have perhaps stage 4 may not have the symptoms, may not have that level of pain, and someone who's at stage 1 or 2 may be very symptomatic and like have a lot of pain within them. So do you recommend surgeries to all women who come to you? Like women who come to you perhaps for cysts, for endometriosis, for fibroids? Is a surgery a go-to treatment?
So it's not one size fits all. We have to completely evaluate the patient. Now, of course, my practice is a referral center, so patients come to me after they've had many, many failed treatments and are in such a bad condition, or they've been so badly gaslit by their attending physicians or gynecologists, or even familial and social structures, so that they start reaching out and doing their own research. And that's how they find me. So by that stage, they're already very advanced, and most patients will require surgery if we, in those cases. But of course, I do see a handful of patients who are early asymptomatic, and if they're not in a terrible condition, we've also reached. So, for example, if I found a patient with a bowel nodule and she has no symptoms, then we have the option of keeping that under monitoring, and rather than putting her through a massively invasive surgery. So those are the rare cases. But in my particular practice, I think most of my work is surgical, because these patients have already undergone failed modalities of all kinds of treatment. They've tried everything from ablation surgeries to just a cystectomy to uh, um, natural therapies to Ayurvedic therapies to even holy waterfall, but they still remain symptomatic because nodular disease is what I specialize in. That
Okay.
is deep lesions in the intestine and in the pelvic side walls that affect the nerves, as well as the bladder and the ureter and all that. So those, unfortunately, the mainstay of treatment for deep endometriosis is surgical as of right
Okay. So when you say that you keep them under observation, like how is that? Like, is that through just an ultrasound or an MR, or or you do have to do a laparoscopy to understand
now.
how deep it is?
No, that's a good question. So it's always the least invasive. So, but it's really dependent on skill. So, ultrasound for endometriosis via an ultrasound at your neighborhood radiologist is a completely different ballgame. So, they only will look at the uterus and the ovaries when they're doing a pelvic scan. They will not look at the relationship between the bladder, the fixity of the ovaries, the fixity of the uterus in relation to the rectum below it, or they will not evaluate the uterosacral ligaments because that's not part of their training. So, will only report on the uterus and the ovary. So unless there's a cyst in the ovary, they will pretty much give you a normal report, even though there may be severe adhesions and nodules in the pelvis. So ultrasound has to be at a specialized center, or I have to do it myself, or there are a couple of other specialists in the country who specialize in endometriosis related ultrasound. The good thing about MR is that I have the option of reviewing the images myself. So whenever I have
Okay.
patients from outside Bombay at centers where I can't really trust a radiology report, I will ask for the MR film and I will review those myself digitally over Zoom as we are doing right now. And coming back to laparoscopy should never be done as a diagnostic tool.
Yeah.
It's
It's a
it is
management tool.
yeah. If you are going in laparoscopically, you should be ready and prepared to finish the surgery. So there's a very
Okay.
famous saying that taking off is optional, but knowing how to land the plane is mandatory. So
Yes.
as when you start surgery, you have a duty to the patient to be able to finish the surgery safely and completely. If you have no training to deal with this advanced endometriosis, even when you put the scope in, and if you've not diagnosed it beforehand and you see a completely frozen pelvis, stops the surgery. If you're not capable of finishing it, and if you've not counseled the patient, obviously, if you've not diagnosed it prior, that you may need to do a bowel resection or you may need to do urethral reimplantation or anastomosis or join them back together, you have no business doing that surgery. You should stop and either refer the patient or not call in an expert to deal with the case
Okay. Great.
after having that conversation with her about possible risks and complications and everything. And again,
Sure.
it's patient choice. You have to present these are your options, these are the risks, these are the benefits, these are the outcomes, these are the possible complications. And the patient, in my opinion, should be as informed about her condition as you are going into surgery and post surgery, because it's informed consent. It's not blankly signing on a piece of paper just to get any kind of surgery.
Yeah, because with endometriosis, I'm seeing that women are in such a state of desperation that the minute that they are told by any doctor or by any surgeon or by any gynecologist, and like I said, that's the first thing that they say, that that you perhaps need a surgery, and this is irrespective of the fact that that they might be at whatever stage or whatever symptoms they have, and women are going for it. And with a lot of women, we see that, the recurrence rate is so high. So why is that? Like, why is a woman getting a surgery for endometriosis and within 3 months, it's back? Why is it so high? And why are we not being able to help women in a way that even if they've gone for that one surgery, then they are, pain-free or symptomatic, symptom-free for life?
So that's a very good question as well, and a lot of advocates such as yourself have asked these questions. And what we need to understand is the difference between true recurrence and disease that is left behind. What an example I always give my patients is, okay, you may have had 3 surgeries in the past, but they've been for cystectomies, or they've just burnt the top of the lesion where the deep endometriosis has been left behind. So in fact, if you had appendicitis and I went in and removed an ovarian cyst, whether I did it 3 or 4 times, you'd still have appendicitis at the end of the day. This is virtually the same thing. If you have a disease in the rectum or in the bladder or around the ureter, and you go in and perpetually do cystectomies, the patient is still going to have bowel symptoms and pelvic pain. So the deep endometriosis lesions are often much more painful than just the cysts. What we need to understand is disease that is actually recurring from something that has been excised versus disease that was completely undiagnosed and not removed in the first place. So when you look at the overall global statistics for recurrence of endometriosis, they're as widespread as 50 to 80%. So when you have that kind of recurrence, you shouldn't be doing surgery at all, because you're not going to benefit the patient if you keep her through revolving door surgeries and you're constantly operating every year or 2. But when you kind of focus that zoom lens microscopically on endometriosis centers across the world, their recurrence rates are less than 0.5% for bowel disease, 5% for deep endometriosis lesions, and about 10 to 15% for ovarian cysts, which are very acceptable recurrence rates. So, and the cysts have a slightly higher rate of recurrence because one would usually not remove the ovary in the case of a cyst. So you would just remove the cyst. So there's always a chance that one would be very respectful of that ovary and not remove too much. And also there is a chance that a smaller cyst can be hiding in the normal ovarian cortex that has been pushed to the side by the giant cyst that you're going to remove. So bearing those things in mind, patients are told that, look, your ovarian cysts have about a 10 to 15% chance of recurrence. But the bad stuff, the deep lesions, we're going to be able to be quite aggressive on those and remove them quite completely, because those are not going to surgically castrate someone by removing an organ or anything of the sort. So even for bowel disease, we're not removing lengths of bowel like they do in cancer surgery. We literally go just above and below the nodule. And they're radical surgeries, but they're also economic in their radicalism in a way.
Okay. So if a woman comes to you for a surgery and say that you've removed all the endometriosis lesions and cysts and everything and cleaned out everything, what do you say to them for post-surgery to be able to not have that recurrence rate, so that the cysts and endometriosis does not come back after your surgery?
So the primary way to prevent recurrence is to remove all disease. Like in cancer surgery, you have to move towards cytoreductive, so reduce the amount of disease. Its optimal reduction is close to 0 residual disease. Okay. Again, it's theoretically a good thing, but there have been studies that have shown microscopic implants quite far away from even your lesion. So there is always some trepidation, and the theoretical clearance of disease is theoretical complete clearance of disease is almost an abstract concept. But we can visually, what we see and should be able to identify, we should be able to remove that too. And those have really good low rates of recurrence once you do that. The next step is that for prevention of this, I would say recovery is a process, surgery is an act. And to heal from surgery and from the disease and the years and decades of the onslaught and the changes that happen within the body because of the disease, that's when the team comes in, the whole pelvic floor physiotherapy, nutrition, naturopathy, even dry needling can help in some cases in terms of acupuncture. There are studies that have shown that works. Of course, we have, I think nutrition, working with a nutritionist is a great way to reduce inflammation. So any inflammatory foods can still trigger a response that can cause what I would say is a hyper response of the gut because of the sensitivity that's already occurred. Now, we know endometriosis works by not only increasing the number of blood vessels, so it is a hypervascular area around the lesion, but also increasing the number and the density of nerve fibers in the region. So the uptake of pain is a lot more, and the uptake of sensitivity. So in the bowel, we know that the nerve plexuses that's innervate the bowel are hyperstimulated. So there's an exaggerated response to any inflammation that can occur. So for someone, it can be spicy food. Someone, it can be caffeine, alcohol, dairy, red meat. So that requires individualistic, tailored therapy with the nutritionist. Pelvic floor therapy with a physiotherapist. Of course, if someone is in pain, there is going to be tightness and trigger points that do need to be worked on and released.
And you already have a set team of specialists working with you?
Yeah, I have a network that I refer to for these kind of cases. I mean, it's a good idea for most cases to receive this kind of care. I mean, surgery is one aspect of it.
So again, but this is not like the first line of treatment that you would say to a patient who maybe has endometriosis or is not too symptomatic or is symptomatic, but is on stage 1, like it does not have very deep endometriosis.
So one is early stage disease is difficult to diagnose on imaging.
Okay.
And if you're doing a laparoscopy for diagnosis, you should be removing the disease, especially peritoneal disease, because it's if you know what you're doing, it is safer surgery and it doesn't take up too much time. Of course, it may be extensive peritoneal disease, but if you're able to dissect your structures away comfortably in skilled hands, it should be a pretty complete surgery, and the patient should recover pretty quickly, and they can be discharged almost on the same day itself. So that if you're doing the laparoscopy, but if a patient is symptomatic and is presenting and you have a suspicion of endometriosis, by symptomatic, I mean any kind of pain, any kind of bowel symptoms, any retention, then you would, give them the option that yes, you may benefit from an excision laparoscopy, or if you want to wait, or if we don't have a chance of surgery, or there's a waiting list depending on what country you're in or what wave of the pandemic we're in and elective surgeries are not allowed, then you have the option of medical therapies. And there are good studies that have also shown that physiotherapy before surgery is also a great preparatory mechanism. And also we do nutrition therapy, especially for the week leading up to surgery, but I think that is more for my ease of operability by preparing the bowel. So we put them on a low residue diet and a low inflammatory diet. So that is to ease surgery and to improve outcomes and reduce complications related to that kind of surgery.
Okay. Yeah, I mean, for in terms of my journey, I would like to share that I had no idea that how important physiotherapy would be in something like endometriosis. I didn't even know that I had a tilted pelvic. And, it's only when I went to my chiropractor and my physiotherapist, all this came out, and it really, really benefited me. And that's what I'm saying, that it's amazing that how, the different elements just add up to the entire recovery and progress, with endometriosis. Doctor, my next question would be, and I don't mean to put you in an awkward position, but what would you say that would be a difference between you and other gynecologists performing surgeries for endometriosis or other laparoscopic surgeons?
So I don't think there's that much of a difference. So my skill set is that I am very focused on endometriosis and advanced endometriosis. So, for example, I do 2 to 3 bowel resections a week. Most gynecologists will not even do one in their careers, and advanced gynecologists, laparoscopic surgeons will do maybe 1 or 2 in a year. So obviously, endometriosis is a whole different ballgame. It is. So I'm a trained cancer surgeon. My fellowship was in gynae oncology, and then later on in endometriosis. So I will give you from personal experience, and so this is not me hypothesizing. This is factual. That endometriosis surgery is much more complex than oncological surgery. It is very easy to do oncology surgery compared to endometriosis surgery, just for the fact that the operable gynecology cancers do not extend into your retroperitoneum, which is under the peritoneum. Endometriosis does, and it does so very badly. So what is considered your safe dissection spaces in gynae oncology is no longer safe. Endometriosis has no respect for those boundaries. So it is very difficult to teach endometriosis and has a very long learning curve. So, of course, there are cases where even I have to, with my experience of doing this almost every day, I have to sit back and reevaluate and take my time before proceeding and be very careful. And every case is part of a learning process. I'm sure even my mentor has the largest series of possibly endometriosis in the world, is still to this day refining and trying to improve his techniques and looking into that. So nobody is ever going to say that they're perfect or infallible, but there is a reason why there are endometriosis centers coming up across the world, because there is a realization coming about that there is even beyond the routine of regular laparoscopy, or you may be the best laparoscopic surgeon in the world. But if it comes to endometriosis and you're not trained for it, you're as good as, say, a first-year resident at handling this disease. Because one, if you can't make the diagnosis; two, if you've not talked to the patient before surgery that you may need to do these things; three, you're not going to be able to handle it during surgery. Those days are long gone where they said, okay, we'll put in a scope and figure it out. Right now, for the main disease, you have to identify it before. You have to have that conversation face-to-face beforehand and respect the patient's decisions going into surgery after she is aware of all the risks and complications associated with surgery and possible outcomes. And then both of you have to tailor the approach and the radicality of the surgery to that and their goals of treatment. Right? So I think that is a very important message to get across, and why it should be handled at centers of excellence for endometriosis with a multidisciplinary team in place. So, for example, if there's a rectal disease, I may have done 100 bowel resections, but my colorectal surgeon has done thousands. So I want the best outcome for my patient. So I will obviously have him or her involved in that resection, because that's their area of specialty. And we have to kind of work together as a team rather than me trying to do something that I may not be entirely comfortable with. So I think getting that approach is a little difficult in our country. First of all, to convince someone to leave behind delivering babies or an infertility practice to focus solely on gynae endoscopy is one thing. And then to give up the rest of gynae endoscopy and focus only on endometriosis is another steep hurdle to cross. So I have a huge challenge convincing fellows to, focus on this one area because in a lot of the smaller states and cities, they're nursing homes. I mean, when I say nursing home, I don't mean it like a small place. They have huge nursing homes, but they are the stars of the show there. They will be doing the deliveries, the infertility practice, the urogynecology, the gynae oncology, and the laparoscopic work. So you're going to have a very mishmash, or literally like a GP for women at the end of the day, rather than a super specialist, which is the need of the day.
Yeah. But considering there's so many cases, I mean, millions of cases, even in India, I mean, apart from what the global number is, but within India itself, there are so many women suffering from endometriosis. Why isn't it this like why isn't it being that much focused on, or, like so much research being done on endometriosis, or like you said, surgeons being trained for it, especially for endometriosis? Or why isn't there an interest even from a surgeon themselves in this area? Because it's a specialized area and they would get so many women, who would want this to be resolved.
So, I mean, it's difficult to say on that because, for one, for OBGYN, which I truly believe obstetrics and gynecology need to be separated as practices now. But for OBGYNs in general, the OB part is the multitude or the magnitude of their patient, the majority of their patient load, right? It's very difficult for someone to give up their practice because that's what they're trained for. So residency focuses heavily on obstetrics and very little on gynecology. Even fewer residency programs have actual laparoscopic work apart from diagnostic laparoscopies. So then the onus falls on the medical practitioner to go and get themselves trained in laparoscopy 1, and then to add on another year or 2 of endometriosis training after that fellowship is very difficult to convince someone to do, because you're taking away from your this thing, and whether your practice is going to work. I mean, there are a lot of variables notes, and the government support is very poor for that. So it's very heavily self-invested. Secondly, there is every gynecologist does some degree of endometriosis surgery, and there is some awareness coming about it. But I think from the laparoscopy training, there is no mandatory fellowship required. So in the end of the day, you can just do a 2-week course, get a certificate from an institution, and start practicing laparoscopy. And a lot of them do. For example, we've had presidents of laparoscopic endoscopy societies in the country who've never managed to do a laparoscopy in their entire lives. But because they have a degree, so they can practice laparoscopy. That is all that is required. So the credentialing is very poor. I mean, it's not only in India, it's in the US as well. So if you have a gynecology degree, it's assumed that you are safe to practice laparoscopy. But of course, there are fellowship programs for 2 years in place now in the States. And so in India, there are no standardized fellowships. There are some from the universities that do allow training, but there's no validation and accreditation of training, and there's no structured training program in place. And then for an endometriosis fellowship, we do offer them, but that is one single center, and it's more about a mentor apprenticeship kind of training program there. Also, coming back to your question, I digressed a little, but I think fact of the matter is it's probably not profitable for doctors to give up gynae endoscopy in lieu of just treating endometriosis. For example, I can't do more than 2 surgeries a day if they're advanced endometriosis, whereas someone who is doing hysterectomies for fibroids or adenomyosis can finish a list of 5 or more a day. And the payouts for endometriosis from the insurance companies are not as much. So if somebody spends an hour doing a hysterectomy and I spend 6 hours doing an endometriosis surgery, the insurance payout is going to be at best equal, on an average, maybe 50% less than what that would pay out. So I think the kind of awareness among the medical licensing and insurance companies is also very poor, because they only think it's removing a cyst, which literally takes 20 minutes to do. But the cyst is not the problem. It's the deep lesions that takes up, time, and especially if you have bowel, bladder, urethral involvement, or the diaphragm or the chest. So those become much more complicated. That is changing slowly because of the work of many advocates like yourself internationally, who are pushing with statistics that we need to reform the ICD coding and, put out fair remuneration for endometriosis surgeries. And that is going to start changing things. And then that surgeries will need to be performed at specialized centers. And there should be credentialing and privileging to perform these level of surgeries. It's not anybody with a gynecology degree can say, okay, I'm going to go do a bowel resection tomorrow.
I'm just going to go back and ask you another question. A lot of women who come, they say that the gynecologist told them to have a baby and, endometriosis will disappear. And on the other hand, they are told that have a hysterectomy. And, especially if you've had children, then there is no need for you to have a uterus and you should just get a hysterectomy done and all your problems will disappear. What would you have to say to this?
So my advice would be, don't walk out of that office, run out of that office. So those are the two biggest red flags when dealing with endometriosis treatments. If your provider is suggesting pregnancy or menopause as a cure for endometriosis, they have no idea what they're talking about. So there's a myth that pregnancy or menopause cures endometriosis. And I sadly still see it being perpetuated today. And I see it in patients from Bombay, I see it in patients from Delhi, and I see it from patients all around the world. So this is a pandemic problem. It's not an endemic one. And we need to understand that medical therapies work on these assumptions as well. So medical therapies like hormonal contraception, either progesterone or the agonist injections, simulate pregnancy or they simulate menopause. So all this is doing is suppressing estrogen. So what estrogen does is it reduces the symptoms of endometriosis. Endometriosis also creates its own estrogen. So the disease is going to continue to progress. Endometriosis tissue is sensitive to both estrogen and progesterone. So the disease will continue to grow and have devastating effects as the more organs it involves and the more nerve fibers it involves and the more laterally it spreads. So that is a very dangerous fallout of delaying treatments. Like I said, that's why we need to monitor it if we are opting for medical therapy. But coming back to pregnancy or menopause curing endometriosis, it's absolutely untrue. I've had patients, only about 30 to 40% of patients actually have difficulty getting pregnant, while 90+% present with pain. So one is you are unwilling to treat these patients unless they are trying to get pregnant, and two is they are made to suffer the risk of pregnancy and infertility, pregnancy loss, miscarriage, and infertility increases because of untreated disease. And three is these patients are unnecessarily diverted towards an IVF route without clearing the disease in the first place. So you're not only deeming them as IVF patients, two, you are subjecting them to live in the pain that they may already be enduring. And three is your success rates of IVF are also going to be reduced, so that financial and emotional expenditure of failed IVF cycles is going to increase. So of course, there is a huge body of literature coming out now showing that you should clear all disease before trying to get pregnant naturally or via IVF. And coming to menopause, I have a large series of patients who have been hysterectomized, oophorectomized, and naturally attained menopause and still have endometriosis outside the pelvis and outside the reproductive organs. So doesn't cure.
Okay. Yeah. That's what happened with me. Like personally, when I went to the gynecologist, I was told that you should have a baby and, it will really help you. And
unfortunately,
likewise.
Sorry, go ahead.
No, and likewise, you come across women who have just been told that if, they've had a child, one or two or whatever the number they want, doctors just recommend directly like a hysterectomy, like, and that's like the end of all problems.
Yeah, that's a little dangerous of a trend, because you see a lot of hysterectomies happening when the disease by definition occurs outside the uterus. And it still exists in the Indian guidelines, so the Indian Society of Obstetrics and Gynecology guidelines. It exists in the European guidelines. It exists in the ACOG, the American College guidelines, that a hysterectomy and BSO, which is removing both the ovaries, should be a definitive final treatment for endometriosis, which is it's archaic, it's unjustified, it's unnatural, and it's stupid, for lack of a better word, because the disease is outside the uterine and the reproductive organs. So how is a hysterectomy going to benefit someone who has endometriosis in the small intestine or the appendix or in the large intestine? Removing the uterus and or the ovaries is not going to remove that disease. Like I come back to my example, if you have appendicitis and I remove the uterus, you'll still have appendicitis. You'll still have appendicitis-related pain. So I mean, that really needs to be re-examined as a therapeutic measure. And unfortunately, this is the training that happens in med schools across the country, across the world, where they are taught that pregnancy is a cure. Endometriosis patients are put on hormonal medication until they're about to get pregnant. Then they are advised to get pregnant. If they can't get pregnant, they're sent to IVF. After they achieve their pregnancy, or if their pain is too much, then they're hysterectomized. And for a subset with extrapelvic endometriosis, they are deemed to live out the rest of their days in pain. And this really needs to change, because I think it's a huge injustice towards women in general, or patients assigned female. And we need to start re-examining this, because I guarantee you, if this disease affected more men, it would have a lot more attention paid to it and a lot more research funding.
Yeah, so I've heard. So Dr. Shivani, last question. What do you think is the future for, I mean, you've largely answered it in terms of future, like what is the future for endometriosis? Is there something that we people can do as well? Like how do we move forward, and how do we make things better for women with endometriosis?
Yeah, so I'm hoping that the future does bring in improved diagnostics, whether it's through blood work or even through imaging. There's research. I'm working on research into automated imaging, where computers can be taught to pick up disease. Of course, that works on a whole algorithm, and this is very early research areas. And also working with the ICMR to study DNA sequencing in patients with endometriosis versus controls. So there's a lot of research going on in different areas to improve diagnostics and to see if they can target genes responsible for the disease and the patterns and the phenotypes of the disease. So
is endometriosis genetic?
There is a good body of evidence supporting that, yes. I do believe that the gene is passed on, but how it expresses and the aggressiveness will depend on other factors, like probably hormonal distribution. It could be something environmental, or and I don't just mean our environment. It could be cellular environment, physiological environment. All of those can also have a factor in it. I think these are factors for people a lot more intelligent than I am to kind of study. I am just kind of trying to do what I can on a smaller scale, whereas help individuals. But I think these scientists have a much broader contribution to science in the terms that they can help a vast number get through. I mean, I'm hoping that I can just fill in the gap till they actually achieve what they're trying to do.
Okay, great. And is there anything we women with endometriosis can do to help in any possible way?
So I think, there's a lot more being done by patients, patient advocates, and the endometriosis groups. So the spoken word is a great way of getting awareness and talking about the disease across. So, in our country, talking about pain, not just period pain, but talking about pain during intercourse or pain associated with bowel movements is related to the period is very difficult to get a conversation going. There's a lot of taboos surrounding this. So I think getting that conversation started is a great step. Also, creating awareness among the community that there are treatments and that these treatments should be handled at centers of care with a holistic approach with a team in place. So not just surgical or medical therapies, but also nutrition, physiotherapy, pain management, alternative medicines, even mental health. So I think that's a very important thing that needs to be looked into, with patients being gaslit for so many years and they're told that it's in your head. Yeah, we can't see it on imaging, so there's no disease. And these questions actually start to question their existence and their sanity and go into a downward spiral. So I think addressing mental health is also very important for that.
Okay, great. You mind me asking you who's your mentor?
Yeah, so one of my main professors I learned from is Professor Horace Roman in Bordeaux in France, and so he is a very, very good surgeon, very humble guy, and very research oriented. So he publishes and he does a lot of scientific process, and he's very dedicated to his craft. So that's something I admire and still look up to. So we're still in touch and we are constantly communicating, and I do consult him for cases that I find flummoxing myself, and he's always there. He's a very busy guy, but he always makes time to help out.
Okay. So is he also working towards endometriosis as a cause, like largely?
Yeah, he does work with a European group, and of course he does lecture quite extensively around the world, and is very willing to give his time to talk about endometriosis. I think we share the same passion for the subject, so it never gets tiring to talk about, although it might get a little toxic for whoever's listening, but it can, I think it does help a lot. But from my experience, I think patients detailing their own journeys act a lot better than a scientist or a surgeon going on about nodule size. I mean, for us, it's more important to teach the next generation of surgeons or the next generation of physicians coming in. But we also should give time to create awareness among the public. But I think that job is much better done by patient advocates and patients themselves.
Okay, great. Thank you, doctor. Thank you so much for your time. It was a pleasure and lovely talking to you. And the session was really informative. And thank you for so many insights as well. And it's great to see someone who is so motivated, towards their craft and towards research and towards, especially this sort of a disease where there are not too many people working towards it. And, it's amazing that, women with endometriosis have someone like you and have an organization such as yours who's spreading so much awareness and doing so much work in this area. And it would be great to have more people like you in the field.
Thank you. It was a pleasure being here. I really enjoyed the session. I thought the questions were quite intriguing, and they're important messages to get out there. So, of course, from your personal experience, and of course, I'm sure you've done your research and everything. And so it was a very good session, I think, and I hope it helps a lot of people out there. So I thank you for doing this and for inviting me on.
Great. Thank you, doctor.
My pleasure.
Bye.
Bye-bye.
And that's it for today, guys. I really hope that this video was helpful and was informative. We both just want to spread awareness about endometriosis as much as possible. So I really hope that any one of you out there is benefited from this discussion. Till then, lots of love.